Now we are seeing the 2-1. Almost the anatomy is looking similar. Okay. Now we will plan for the second premolar or first premolar. We don't know. Okay. Okay. Now we will keep the implant separate and we will read the anatomy. This is the first premolar or second premolar. We don't know. Okay. See the outline. First, see the crestal cortical bone, the surrounding cortical bone, the C2. C2, now there are two C2 available here. So this is the nasal floor. This is the sinus floor. Okay. This is the inferior turbinate. This is the septum. Septum, if you see, it is deviated. I think the patient will have a deviated nose, we can see. Okay, this is the palate. Okay, so this is the palatal soft tissue. It's very thick. Okay, the intramedullary is cancellous. It is not very cortical. See the But however, if you place a compressive implant, it will compress this loose bone into a tight bone. Okay. So the width, the length up to, you can go here, you can go here, or you can go here. From here, can you go here? Not possible. From here, you can go only here. That means nasal floor. Okay. What is the length available? So up to here, it comes around 18 mm. Okay. So what you have to do is, you have to keep one finger palatally, keep the finger palatally, and do the drilling along the palatal finger. Okay, you will reach here. See, once you drill here, it will be very hard. But after that, it will be soft. But once you reach here, you will feel the hard again. Once you cross this, suddenly you will feel the drop. Okay. So these kind of variations you have to feel. So during drilling, or these kind of things will happen in your mind. Okay, I am going through this. So you have to do the drilling part slowly. Which drill? Bilateral. So bilateral, everything happens. So the most important in implant surgery is the bilateral. If you do the bilateral properly, then you will get the length, everything. If you do the bilateral properly, you can hand over the entire all the surgeries to your assistant and control. So it is a very much important. Wherever the flight goes, wherever the pilot goes, the entire flight goes. The entire 200 people life is in the hand of the pilot. It's very essential. The same way, this pilot, the entire life of the implant lies upon this pilot. Okay. So we will see the 360-degree view. It looks good. Now we will see the Hounsfield unit. You can see the Hounsfield unit. It is around 900 something, but near the nasal floor it is 1000. Okay. You may be asking, can we use basal design here? I won't be using, because the basal design gets support only from the here. The other shank part, it doesn't get any major support. But if I use a compressive, it gets support from the crestal bone. It gets support from this alveolar bone, intramedullary bone. It gets support from the nasal bone also. From 3 areas it is getting the support. But if I am using basal, it will get support only from here. So not always blindly use the basal design. If the same patient, if there is no labial plate, I may be using basal. Okay. So 1-1 implant is over. 1-4 implant is over. We will see the 1-6 palatal lobe. Now we keep this segment. This is the 6 cross section. 6 section, there may be some palatal decay, we don't know. Okay, this is the palatal socket. This is the mesiobuccal root. This is the zygomatic buttress. Okay, you can see the white radiodextrin. See, the sinus is very beautiful. See the outline first. See, the sinus floor is quite dense. The nasal floor. And another misconception is, people think nasal floor is present only between the canine to canine. It is not that. The nasal floor goes till the 8. Till here its sinus floor comes. Sorry, nasal floor. Okay. So this is the palatal socket. See the palatal wall, how dense it is. If you use a 5.5 basal implant, it will get support from the palatal cortical bone. Not necessarily it takes support from the nasal or sinus floor. It will take support from this palatal. So palatal socket wall, palatal socket wall is also a kind of C2. The palatal socket wall of palatal roots of molar. It is also a cortical bone. Okay. Here what I can use is, I can use a wide diameter 5.5 implant, or I can go beyond the apex and I can go wherever it goes. 5 minutes. See what I do is, after extraction I will do the drilling, go till I feel some stop, then I can place implant 4 into 16 it shows. Okay. Something between 13 to 16 I can select. So palatal socket of 6 we are using. Just for discussion sake we will keep only the 7 also. Okay. If you see the 7, see the outline. The bone is very cancerous, very porous. It's not a very ideal scenario. Okay. The palatal bone is also very thin. Okay. So it's not very much ideal. We leave it. Not necessary. Now we will place in the if we consider it as 7, mostly this will be a 6 now. This area. Okay. So this is the 6 area. See the outline. Okay. The intramedullary bone, the sinus floor, nasal floor. So you can start the drilling from here to here. Okay. So if there is no CBT, what you do is you hold this ridge in your finger, buccally one finger, palatally one finger, and you do the drilling between your 2 fingers. Okay. Wherever you are feeling that resistance and drop, measure that and you place implant. So from crest, I can place like this, or slightly. Imagine if you can able to tilt palatally, you can place a longer implant. Can you understand? Small, just keep the finger here and tilt. You will tie this. Okay. If you don't want to complicate anything, just place straight. Or if you want to try something, you can go till here, longer implant. Okay. Since we are placing multiple number of implants, you don't have to do such kind of thing. A short implant around 10 mm it shows. 10 mm implant is enough. Okay. So what is this part? Can you tell why there is good bone here and there is less bone? Because this is the old location of the palatal socket. Previously palatal socket was present here. So there you got the good bone. Okay. So this is the 6 area. That means just in front of that lone standing teeth. You will place one more in front of it. If you see here, there is ridge resolved. Somehow the ridge is not. You can go like this. This is one option. But what I was planning is like this. Start the drilling palatally and go like this. Okay. Instead of drilling through the crest, you can keep the implant like this. If you place implant like this part will be exposed, the compression threads, but it is accepted. Exposing the rough threads on the palatal aspect is okay. because the palatal tissue is very thick, nothing happen. The rough threads should not be exposed buccally, but some threads can be exposed. Even in conventional, you can place a conventional implant and you can leave these threads open because the palatal tissue is very much